All right. I'm going to go ahead and get us started today. So welcome everybody to our CFAR Public Health King County LunchBox talk. I'm super excited for the two speakers that we have today who are going to be speaking on the successes and challenges of implementing low barrier care, experiences from the Aurora and Engaged Health clinics. So let me quickly introduce our speakers before we pass the Zoom room over to them. So we have Dr. Maria Corcorran, who is an assistant professor in the Allergy Division of Allergy and Infectious Disease at UW. She's the medical director of the Aurora Clinic, a community-based low-barrier clinic focused on HIV prevention. Her research focuses on strategies for expanding low-barrier care to people who inject drugs. And Dr. Jimmy Ma, who is also an infectious disease physician and the medical director of the Engaged Health Federal Way in Kent clinics, which are two walk-in clinics focused on prevention and care of HIV, STIs, and substance use. His research concentrates on expanding and improving care for individuals who use substances and HIV prevention. And those two clinics are newer clinics in terms of our low barrier care clinics in King County. And so we're super excited to hear about the experiences at all three settings. And so welcome Maria and Jimmy to the space today. Thank you for coming.
Thanks, Jen.
Thanks for having us.
Yeah, thank you all. I'm going to share screen. Tell me if you all see this okay. Yeah, how does that look for you all?
That looks good, Jimmy, to me.
Awesome. There's no extra stuff like text boxes or anything. All right, I will go ahead and get started.
Great. All right. Well, thanks everyone for coming to the talk this afternoon. It's really a pleasure for Jimmy and I to be here to discuss the She and Aurora Clinic and the Engaged Health clinics with you today, both of which are status neutral, low barrier care clinics in King County. And we'll go into that a little bit more in detail during this talk. Next slide, please. So neither Jimmy or I have any disclosures. And next slide. So today, the outline of our talk that we'll be discussing today, we're going to really ground this discussion in what is status neutral care and talk about that for people living with and without HIV. And then we'll talk about some of the key elements of low barrier care that we think are important for our clinics. We'll give a description of the She and Aurora clinics, as well as the Engaged Health clinics, just so you have a better understanding of the type of care that's provided and how it's provided. And then we will discuss some key implementation characteristics for our low barrier clinics that really make them work. And then of course, some limitations and future directions. All right, Jimmy, I'll turn it over to you.
I am muted. Okay, thanks, Maria. I'll start us off by giving an intro on status neutral HIV care and what we believe are some of the key elements of low barrier care, just like Maria mentioned. In this day and age, we have a lot of tools to reduce or eliminate HIV, such as PrEP, really well-tolerated and potent ART. Recently, the advent of long-acting injectables have really opened up our toolbox as well. However, oftentimes folks aren't able to access these fully in order to get the benefits of both the prevention, the treatment, and the care that over time science has been able to provide. HIV care has historically been organized and conceptualized often as prevention and treatment arms on multiple levels, depending on the jurisdiction, from the clinic to the health system to the department, all the way up to funding. And as you can imagine, this can lead to difficulty navigating services, challenges with coordinating care, and oftentimes redundancy of services at the clinic or service level or systems level. Additionally, many barriers, often social determinants of health, prevent patients from fully accessing the benefits of these services. This could be things like housing, transportation, insurance, mental health, or even substance use. Services for these aren't always offered alongside traditional HIV care and prevention services. And so additionally, clients may also see, traditional settings and messaging for HIV and STD care as stigmatizing and not really want to engage in care in those places. And so for all of these reasons, the status neutral philosophy and model really tries to address these historical challenges from a person first, not disease first approach. The idea is to provide care for the whole person through a one-door approach. I'm using a lot of buzzwords here, but that essentially means providing treatment and prevention care in the same place alongside comprehensive social and medical services. The focus becomes individual health and well-being with the hope of normalizing HIV care and prevention. That's a key aspect of this. And all of this is built on a foundation of being trauma-informed, culturally affirming, and inclusive, which when taken together, hopefully can address some of these prior social determinants of health and other barriers that I mentioned, and help an individual reach their own health goals. Maria's going to talk to you a little bit more about the idea of syndemics, but at the center of all this is taking a person-centered approach to address what a person needs. Several important components to status-neutral HIV care that have been identified by the CDC include healthcare that encompasses HIV testing, treatment, and prevention services. Having these services with other healthcare services such as sexual health, LGBTQ focused care, substance use therapy, mental health, and primary care. The key idea that these are integrated together with broader services such as housing, food, transportation, harm reduction services. And then kind of what I mentioned, the bedrock of all of this being culturally affirming, stigma-free healthcare provided by supportive and accepting providers who are well-informed and well poised to help our people in need. This figure here, if you can see my mouse here, is from the Texas Department of Health. It's really great because it highlights the status neutral framework from being centered around the person, with the various services informing and helping a person achieve their own health goals, interfacing with these various HIV care services, whether you consider the prevention continuum or the care, the HIV treatment care continuum. Said in another way, the status neutral approach takes a slightly broader view, but has many of the fundamental elements of the differentiated service delivery lens that many of you may be familiar with, including the core idea of adapting services and systems to the patient rather than the one-size-fit-all model that potentially the traditional healthcare model may have. And so, framed differently, the goals and potential benefits of status neutral care are ultimately seeking to address the social and structural barriers to engaging in HIV prevention and care by prioritizing the needs of individuals and communities. And this hopefully reduces stigma and bias, making health and well-being more the center rather than a person's HIV status. It also helps to meet people where they are, ideally providing it in places and ways that are best suited for patients. This care is ideally provided in a culturally and linguistically affirming way, improving equity and reducing disparities, and can also create opportunities to connect services, thereby increasing accessibility and efficiency by breaking down walls between different healthcare entities. One example, and this is actually the first place where status neutral care was developed, was in New York City. They rebranded from a systems level their sexual what they call STD clinics. They rebranded those as sexual health clinics and used that to reduce stigma, enhance the right medical case management program. And together with that, between 2016 and 2019, they reported a 22% decrease in new diagnoses and found that the integration approach was very, very helpful and deliberate in providing collaboration and required, but they were ultimately needing that whole systems level approach to kind of achieve these outcomes. So moving on to talking about a couple of key elements of low barrier care. These are some of these structural elements. We talk about low barrier care in a lot of different ways. And this table provides a really nice way to kind of ground some of our discussion, and we'll be referring that back to that later in the talk here. This is from a recent review by Julie Dombrowski, Meena Ramchandani, and Matt Golden. And I really want to start kind of in the middle here, this low barrier. So there's this, they divided it into very helpfully structural elements and process of care elements. And I'd like to start with this low barrier care philosophy here, which is this adapting care goals to reflect the individual patient priorities and abilities. That kind of mirrors or echoes some of what I mentioned earlier about status neutral care, kind of centered around what an individual needs. This really means streamlining care. We're changing the system to fit what a patient needs, including shortening visits if needed by clients, harm reduction approaches, not just the substance use, but even in the management of comorbidities, which may involve postponing best practice or guideline-driven care, and creating new creative plans for our patients. Additional elements here include multi-sector coordination with other folks in the community, other agencies who have expertise and have the trust of our patients, and working with them together to help create a network for our patients, and a commitment to rapid change as we need to, based off of feedback from our patients and our community partners, in an iterative process. Other structural elements here, which is what we give and how it's delivered, include walk-in access to care rather than appointments, creates that flexibility, an integrated team with care managers that allow for some of that navigation and connection with services. Incentives are listed here, but in how status neutral and low barrier care has been implemented in other jurisdictions, it's not always a specific aspect of that care, but it is something that is a part of both sets of status neutral clinics, both at Aurora and Engage clinics, and we'll talk more about that later to you all. It has been used for incentivizing either lab draws or testing or HIV outcomes. But also, if you want to think of the idea of incentives as being broader than just money, gift cards, it also includes transportation, other things that provide support, food, clothing, hygiene items, and stuff like that. So the idea of incentives is fairly broad, and I don't want you to just think of it as just simply cash or gift cards. So here is kind of a nice little timeline of how the various clinics were developed and evolved over time, starting with Max Clinic, all the low barrier Madison clinics, and also kind of a map of where they are. Today, we're going to focus mostly on the status neutral clinics. So that'll be She Clinic, Aurora Clinic, and then the 2 Engage clinics. And looking here, you can see that She and Aurora Clinic are up here in North Seattle, whereas Engage Health is down here in South King County. The other distinction between outside of being just in the community setting and being a little bit later is that it's outside of the central Seattle area where Max Mod and Madison Clinic are, and which serve primarily folks with HIV, though Madison Clinic also serves folks without HIV as well. And then, so what I hope we can illustrate for you today is that this network and the spectrum of care, that overall this network is able to provide for you a spectrum of care that takes the low barrier clinic and care philosophies and the status neutral philosophies that I just mentioned, and integrates them in ways that are meaningful to both the local community and our patients. So with that, I'm going to pass off to Maria.
Great, thanks, Jimmy. So before I talk about the specifics of She and Aurora Clinic, I really wanted to first kind of ground us in the syndemic of issues that are really affecting persons living unhoused in King County, and specifically those that we see up at in North King County, where I'm going to talk about She and Aurora Clinic. So I think we're kind of accustomed to thinking about the syndemics of HIV and STIs and substance use, and also viral hepatitis can go into that. But I think the other big things that we really have to think about contributing to HIV risk or contributing to risk for STIs include violence and trauma that's been experienced throughout many of our patients' lives, as well as untreated mental health disorders, which are quite pervasive in the populations that we serve. And so this figure to me really encompasses some of the big buckets that we are kind of grappling with in a synergistic and syndemic way at both the Aurora and She Clinic, as well as the Engage Health clinics. Next slide, please. All right, so the She and Aurora Clinic, I'm gonna just caveat this by saying I use the term She Aurora Clinic because even though they were started at different times, really they're kind of one and the same. And I'll discuss a little bit about the differences in different days, but they are housed within the same clinical space. And so I'm going throughout this presentation to be using the term She Aurora Clinic as kind of a single entity. So how were these started? In 2018, in response to this syndemic of health concerns that were affecting people living unhoused in North Seattle, and specifically women, Dr. Shreesha Danareddy and others at Harborview and UW Medicine decided to open the She Clinic, which stands for Safe, Healthy, and Empowered. This began as a status neutral, low barrier walk-in only clinic for female identifying persons. And it was run by Harborview, but housed within a nonprofit organization called Aurora Commons, which is up on Aurora Avenue on 90th in Aurora. And this area, as many of you probably know, has been a hotspot for drug use and sex work in the North Seattle neighborhood. And so that was why this area was chosen. And I will say that this was actually before the outbreak in 2018 of HIV. And so the clinic opened sort of concurrent with this outbreak. And it wasn't actually in response to the outbreak, but was just a very advantageous location for us to be in during that time. Next slide, please. So the She and Aurora clinics are housed within the Aurora Commons, which is a community-based nonprofit organization that really describes itself as a community living room, and it provides a welcoming and safe day drop-in space for unhoused neighbors. And through their drop-in space, Aurora Commons provides a daily meal, they provide coffee, access to kitchen space, they have laundry for neighbors and bathrooms, and they also allow their neighbors to have mail delivered to Aurora Commons. And they offer non-medical case management through advocacy services. And the advocates typically help out with things like getting people on housing lists. They can help them get phones. They can help them get IDs and a variety of those types of non-medical case management services. Next slide, please. So the She Clinic, as I mentioned, initially opened in 2018. And this was really thanks to funding from the Washington State Department of Health, HIV prevention services. And when it first opened, She Clinic was actually run out of a mobile medical van that was owned by Lehigh Health. And this medical van would park outside of Aurora Commons right along Aurora Avenue on Wednesday afternoons. And so She Clinic was run out of that for at least the initial, I think, 1 to 2 years. The clinic at that time was staffed by a doctor, which was Shrisha Bannareddy, a nurse, and a social worker, and received support from the Aurora Commons advocates, who were also funded to do their work from a separate pot of money from the King County Health Equity Fund. Then about 2 years later in 2020, She Clinic received some additional funding from King Counties, and that was from the King County Healthcare for the Homeless Project. And this allowed She Clinic to expand not only from Wednesdays, but to Wednesdays and Thursdays. And it was around that time that She Clinic actually moved out of the van and into a church office space that was just on the corner in a building that's sort of all attached to Aurora Commons. And then in 2021, Harborview Medical Center, as well as Aurora Commons, were joint recipients of the Public Health Seattle and King County and the HIV epidemic funding. And that allowed Aurora Commons to expand their day drop-in space and build us out a clinic space that's housed in the back of Aurora Commons. And this clinic space is actually where I'm sitting right now, and is complete with 2 clinic rooms. It has 2 bathrooms and a small waiting area. And this funding that came in 2021 also allowed us to expand clinical services from just Wednesdays and Thursdays to 4 days a week. So we now operate Mondays through Thursdays. And the reason that the name change happened is because while She Clinic was initially on Wednesdays and Thursdays for female identifying persons only, the funding allowed us to expand to male identifying and non-binary individuals. And we provide care for kind of all persons on Mondays and Tuesdays, and have kept Wednesdays and Thursdays kind of female specific days to try and have a protected space for many of these women who are quite vulnerable. So because we didn't feel like men would necessarily want to come to something called She Clinic, we term Mondays and Tuesdays Aurora Clinic, and we term Wednesdays and Thursdays She Clinic. But essentially, it's the same kind of subset of services that are provided. It just depends on who's able to be seen by the physician on which day. Next slide, please, Jimmy. So in terms of our staffing model, this is a kind of a schematic of the current staffing model that includes on any given day, an MD, 2 RNs, 2 social workers, and a PC. So our PC helps with clinic coordination, follow-up, helps us manage some of the incentives, etc. And so how the RN time and the social work time are divided, really is kind of along gender lines. So one social worker primarily focuses on supporting men and non-binary individuals, and then the other social worker focuses on female identifying individuals. And then the RNs kind of go back and forth, but one kind of takes the lead providing care to female identifying folks, and one takes the lead on providing care to folks who are male identifying or non-binary. And then we're also supported in this work by the Aurora Commons advocates. Typically there are 3 to maybe even 4 advocates on any day. And then there's a drop-in manager, and then of course the executive director that we work closely with as well. And so this is kind of what the team looks like on any given day. Next slide, please, Jimmy. In terms of what happens when somebody comes into clinic, so the first step is that they will come into the general Aurora Commons drop-in space. And at the back of the space where the social workers sit, there's a sign-up sheet. And people will just put their name on the sign-up sheet if they want to be seen by clinic that day. We just ask for a name. We don't ask for any other identifying information. And people don't need to specify what they want to be seen for. Once people are on the list, then there's usually some kind of brief triage conversation that happens that's either done by the PC or one of the nurses of just, hey, what are you hoping to be seen for today? And that kind of helps us understand, is this something that can be dealt with by one of the nurses? Maybe somebody just wants to follow up on their STI testing results, or is this a more kind of MD appropriate conversation? And then once that happens, we do have the clinic visit that happens in one of the 2 clinic room spaces. And this looks like most of your traditional clinic visits. And there's a variety of different things that we kind of focus on at these clinics. So we provide what I like to call primary care light with some chronic disease management and referrals to outside care. Jimmy had mentioned in his overview of the low barrier care that sometimes this low barrier care philosophy, when we're really trying to meet the person where they're at, provide sort of person-centered care and harm reduction care, oftentimes we do have to defer some kind of guideline recommended care, things like mammograms, colonoscopies, right? Some of that gets deferred to really focusing on the more imminent and immediate needs of that individual. We also provide STI testing and treatment. That's a big thing that we do up here in the North End. We have a lot of people who are engaged in sex work. And so we do a lot of frequent STI testing and treatment. Of course, HIV testing and treatment. We do provide primary care to people living with HIV, have people on PrEP. We do PEP or post-exposure prophylaxis here as well. We provide viral hepatitis testing and treatment and do treat hepatitis C and have some folks who are undergoing treatment for chronic hepatitis B. We provide medications for opioid use disorder, mainly Suboxone. But we will also provide referrals and kind of expedited referrals to methadone clinics. And then reproductive health care, pregnancy testing, referral to OB is something that's a big focus for the SHE clinic patients. And we do diagnose quite a few pregnancies here. And we've actually established a nice collaborative partnership with the Northgate Family Medicine Clinic to do expedited referrals. And I'll mention that a little bit later in this presentation. And then we provide gender affirming care, basic abscess and IND care, wound care. We have some medication delivery, and that happens through our partnership with the Harborview Long-Term Care Pharmacy, or otherwise known as Kelly Ross, where we are able to get medications delivered directly to Aurora Commons for pickup here. And then all labs and referrals are usually sent within the Harborview or UW system. So because we are located close to Northwest Hospital, we will oftentimes refer people there for specialty care or imaging, but we'll also do referrals down to Harborview as well. And then all of our labs that are drawn on site are centrifuged here, spun, and then couriered back to Harborview for processing. Next slide, please. So just in terms of the impact on harm reduction and preventative care uptake, these are some older data. But what I'm showing here are surveys, 2019 surveys of 76 women at Aurora Commons, 41 who had accessed SHE Clinic, and 35 who had not. And then these data are from women who consented for abstraction. And what you can see is that amongst the SHE Clinic patients, these 41 who are sort of early adopters, and the SHE Clinic non-adopters, There were people who adopted She Clinic were more likely to have recent STI screening. They were it wasn't statistically significant, but kind of had a trend towards more STI treatment. That people had more reported more opioid replacement therapy, and nobody who had not accessed She Clinic had been prescribed PrEP, whereas a much higher percentage, almost 49%, had a PrEP prescription who had been seen by She Clinic. Next slide, please. And then similarly, this is data again published by my colleague Janelle Stewart, who looked at ED visits per woman before and after implementation of She Clinic. So Dr. Stewart and Dr. Maggie Green looked at non-emergency emergent care, so people who access the ED for kind of non-emergent reasons, and then people who access care for emergency reasons, something that couldn't be dealt with at kind of a primary care clinic setting. And what you're seeing here is the blue lines are the non-She Clinic patients. The darker is the non-She Clinic patients before implementation of She Clinic. The lighter is the non-She Clinic patients after implementation of She Clinic. And then the green lines are the She Clinic patients, so folks who had accessed She Clinic, the darker of which is before She Clinic opened and the lighter of which is after She Clinic opened. And you can see here that there's a sizable drop in the non-emergent emergency room visits among She patients, where you don't see that amongst the sort of control setting patients. But there wasn't any difference in emergent emergency room visits, which one might expect. Next slide, please. And then this is just unpublished data that I kind of amassed with my colleague, Dr. Janelle Stewart, looking at buprenorphine continuum of care amongst She Clinic patients. So we do know that She Clinic, at least in its kind of early stages, had a really good impact on STI testing and treatment, had an impact on PrEP uptake, had an impact on decreasing non-emergent emergency room visits. But it's not all sort of like roses and sunshine, right? We still do have some ongoing gaps in care. And specifically, I think those gaps really focus on sustained use of some of our biomedical interventions. So sustained use of PrEP, sustained use of MOUD, or specifically buprenorphine in our case. And so these data are looking at what we call the buprenorphine continuum of care among She Clinic patients who accessed care in 2019. So amongst 110 people who had a visit, 45% were prescribed buprenorphine, and about 22 of those people had a follow-up urine drug screen, or just 44% had a follow-up urine drug screen, with only 6 having urine positive for norbuprenorphine, which is the major metabolite of buprenorphine that you can see in the urine. So we can see that there's quite a big drop-off in terms of people who are sustained on buprenorphine in our clinic. And I think a lot of that has to do with just the need to take something daily or multiple times a day, and a lot of the chaos that people are dealing with and competing needs that people are dealing with on a day-to-day basis. Next slide, please. Okay, I'm going to turn it back over to Jimmy.
Thanks, Maria. So I'm going to talk a little bit about the Engage Health low barrier clinics now. Engage Health is really an offshoot and kind of an evolution of the She Aurora model, and also what was learned there in many different ways. It started off with Public Health Seattle King County, and I think several of you here are well familiar with the story, but there was some need to address some of the HIV epidemic down in South King County, and these partnerships were built together over the course of that, and I'll get into a little bit more in the next couple of slides. The Engage Health clinics, they're 2 low barrier clinics for individuals at high vulnerability or with HIV living in South King County, a la the status neutral model. And it's a partnership between Public Health, Harborview, which includes the Madison Clinic, as well as the office-based opioid treatment team, providing some of the medical expertise, and Catholic Community Services of Western Washington. Together, all of these clinics and the initiative is supported by Ending the HIV Epidemic funds, as well as HRSA Ryan White funds, and because of the OBOT presence, a SAMHSA grant as well. Federal Way opened, as shown earlier, back in December of 2022, and Kent is opened up in the end of August of 2023. So, as I mentioned, the Engage clinics were put together in response to some of the knowledge that was gained from the Aurora clinics, as well as additional funding and availability of money through the EHE initiative in 2019. It allowed for public health to expand HIV prevention and care services. And as you can see here, this is from the HIV epidemiology report in 2020. This dashed line in South King County showed that the rates of folks with HIV was the highest at that point in both South King County and in Central Seattle. But this was where a lot of the epidemic was. And in South King County, there was a gap in what services were available and the high need. Many of the new diagnoses, as well as prevalent cases, were there, and there weren't a lot of HIV services there. So this what presented an opportunity for these new clinics to be built out. Identification and development of the various partnerships occurred over the course of the following 2 years, and then build out occurred, as I mentioned, in 2022 and 2023. So, speaking to a little bit about Catholic Community Services, it's a branch of the Catholic Church, and it provides a variety of programs serving the community, including housing services such as shelters and supportive housing. It also provides drop-in spaces like day and hygiene centers. In these day and drop-in centers, they offer a lot of services for non-medical case management, such as phones, insurance enrollment, referrals for food and legal assistance. One of their key initiatives is their Crew Mental Health Service, which I'll mention a little bit more later on as being a key partner for some of the great things we've been able to do with our Engage clinics. Just like Aurora Commons had established relationships within the community, Catholic Community Services in South King County was the primary provider of services for folks who are unhoused or living in unstable housing, and already provided many of the services such as mental health services and non-medical case management services that were crucial in creating a successful and welcoming environment for our clinic. And so they were a natural partner to reach out to, and had the trust and expertise in a lot of these areas. So to talk a little bit more about the Engage Clinic model, it's an adaptation of the Aurora Clinic and Aurora Commons model, where there are groups of nurses, program coordinators, an MD, and social worker. However, it's organized a little bit different because we have 2 sites that are running concurrently. So this just organizes things a little bit differently. Each of the clinics has their own set of nurses and program coordinators, which the nurse and the program coordinator, when we're fully staffed, becomes almost the site expert of their community. They are the site expert, also working with various advocates and CCS staff on site. Because of our funding sources, we had one spot for MD and one spot for social work. And so as a result of that, the MD and the social worker bounce between the 2 clinics. And on the day that they're at the opposite clinic, they offer remote services via phone, via Epic. And so that it allows us to extend our reach and allows us to kind of provide services that otherwise wouldn't have been there almost every single day when we're fully staffed. Similarly, the CCS team also has a similar structure where the executive director and the site manager also bounces between the 2 day centers as well. And so together, when we're fully staffed, this has allowed us to open up and allow more touch points for care. Oh, it's not advancing. One moment here. So the services that we offer are very similar to those that she and Aurora provide as well, and the structure and flow are generally similar as well. Each of the various clinics have a slightly different layout in terms of the actual building, and so some of the flow is a little different. For example, at Federal Way, there's an entry point where there's a lobby where it opens directly to the day center as well as into the clinic space. So check-in and all that kind of happens simultaneously with the actual day center services. Whereas in Kent, there's a slightly offset where there's, excuse me, a door that actually divides the clinic spaces from the day center spaces. And oftentimes the clients either first check in with the day center, they Teams message us and say, hey, we have someone who's interested in services, then they come over, or sometimes clients will just directly come in through the clinic door. We find out that they have other needs and we direct them to talk to the CCS team. So slightly different, but we've been able to kind of slightly different flow, but we've been able to kind of adapt various models to the various sites. The services are fairly similar with the same kind of primary care light with a focus on STI, HIV testing treatment, as well as opioid and substance use treatment. But we also do address chronic disease management and referrals, reproductive health care, wound care. We also have medication storage on site, so deliveries can be sent to the various clinics and we store them on site and the patients can pick them up as well. We had an earlier partner, which was Metropolitan Medications, which served us really well in the South End, but they unfortunately closed about 2 months ago. And so we've luckily been able to work closely with Harborview Long-Term Care Pharmacy, and they've been able to deliver instead of every day like up at She and Aurora Clinic, they've been able to do once to twice a week deliveries down here, and that's been working well for us. And similarly to She and Aurora Clinic, we can serve as a telehealth center here, where if folks have virtual visits with specialty care or other organizations, we can serve as a hub, and our team can serve as a assist them to make those appointments. That's especially important down south because in South King County, it's much more suburban, more rural, and so services are much more fragmented and spread out as compared to Seattle, where services are often and health systems are more collectively closer together, and it's easier to send someone between different organizations. Additionally, the UW system often has more concentration in Seattle, and so something that we found is down south, we've had to coordinate and work with multiple different systems such as Multicare or CHI Franciscan. And we often see folks in Federal Way, especially in that gray zone between Tacoma and Pierce County and our clinics there. So in response to some of the spread outness and some of the structures being a little bit different and some of the presence of MD and social work being less, we've adapted some of our services to be a little bit more nurse-centered. And one of those examples is the office-based opioid therapy, which we use. Some of you all may have heard of this, is the Massachusetts model, where the nurse is actually the center of the Suboxone buprenorphine team. And so that allows for more touch points. A provider doesn't have to necessarily be there. A prescriber doesn't necessarily have to be there. The nurse can lead the conversation either on phone or in visits. Outside of the initial visit, additional refills or additional adjustments and therapy can be done in a more decentralized fashion. That also, because of our more recent staffing shortages, we've had to be more cognizant about doing remote MD support. And so oftentimes, both Maria is well known, Maria has helped us a lot on days where I'm not available or there isn't an MD available. And some of the She Aurora Clinic doctors as well have been helpful to, if there's like a wound that needs antibiotics, we'll do more remote MD support where a a photo will be sent over Epic, and we've been able to do more nurse-driven led care for STI treatment, for such as like antibiotics, or even for HIV testing treatment. Labs can be thrown in. We can do like remote visits over the phone with patients. So we've been more creative in those aspects, or we've had to it due to some of the limitations in our model. And finally, CREW is a CCS mental health arm. They have outreach and also prescriber services. And so they don't have same-day services, but if someone is in crisis, they typically have someone who can help with that. And we have collaborated very closely with them, and that's been a wonderful collaboration between our team as well as CCS's. Noticing time here, I will kind of go through this a little bit more quickly. These are some numbers for folks with HIV, and that we've some quick numbers over the last year at Engage Federal Way in Kent. We've served about 361 unique individuals at Federal Way, about 160 at Kent because of the later start. We've had frequent testing. These are unique individuals. We sometimes have more regular frequent flyers, so to say, and so some of them have ongoing risk, and so we test them multiple times. And then this is the total number of folks that we are either seeing regularly or as part of the overall network that I mentioned earlier on of Madison HIV services have seen us. So 40 at Federal Way on average, and around 11 at Kent. And the numbers actually have changed in the last 5 to 6 months and have increased a little bit for both of these groups. We don't have necessarily more concrete numbers like she and Aurora have because of our newness, but we've done some great initiatives. One of the things that we did was back in November of 23, we had an open house just shortly after Engage Kent opened, and we were able to see a lot of folks provide our services, provide an introduction to the community. Just that one day, we saw 24 folks. We had 2 new starts on Suboxone, multiple people tested for HIV, actually diagnosed a couple of folks with syphilis and got treatment for them. 1 new Hep C diagnosis that we were ultimately able to get treatment and has actually achieved cure. And we did a lot of harm reduction, a lot of naloxone kits, and safe use education that were sent out. And this was actually a really great connection, a really great event that we were able to get the community excited. CCS, along with the city of Kent, multiple different folks came through. It was a really great event, and we're hoping to do more in the future. And then just some quick narrative impacts here. I'm not going to go read through this, but we've been able to meaningfully impact care for a lot of folks on the individual level, keep them engaged, get them additional needs, or just through our care coordination, able to get folks and move their care forward. For example, even someone at who was didn't have HIV, we're able to get them. Where was it? This person here, able to get them a new valve and housing up in Ballard. Even though we don't see this person anymore, you know, they've been able to be successful and get connected further on. And multiple folks with HIV with complex needs, we were able to help them in their care. So I just wanted to highlight that. I will pass it over to Maria now.
Great, thanks so much, Jimmy. So just to kind of round out our presentation, I'd like to talk about what are the key fundamental implementation characteristics that really make these clinics successful in engaging and caring for a very marginalized group of unhoused individuals, many of whom are using drugs and or engaging in exchange sex. And while I think there's many characteristics that we could highlight about both She and Aurora and Engage clinics, we've chosen 4 here that we feel are really key elements that are critical to the success and would be essential components for future implementation and scale up of other similar clinics. And the first, and I think perhaps the most important here, is the partnerships that we have both with Aurora Commons and with Catholic Community Services. We can really do the work that we're doing because we are embedded within trusted partners within the community. I do not think that we would be as successful in the work that we're doing if we were just out here on our own as a Harborview clinic. We're really seen as friends of friends. And I think that gains us a lot of buy-in and allows folks who traditionally haven't accessed the medical care or have been stigmatized during ER visits, have felt sort of re-traumatized by medical care, really do see us as more of a safe haven for getting some of their needs met. Next slide, please. I'd also like to highlight both the trauma-informed care approach and also what I'm calling a trauma-informed environment. So both at She and Aurora and at Engage Health, the care is intentionally trauma-informed, and it aims to have a small footprint, meaning that the patient priorities are really at the forefront of care, and individuals hopefully aren't made to feel subjected to unwanted medical interventions or care that they didn't ask for. And so in the clinics, we really prioritize the individual patient needs, meeting people where they're at, really at the cost of higher throughput and efficiency, which I think are unfortunately sort of cornerstones of many modern day medical systems. And I think this focus on the individual patient care and being trauma informed also means that sometimes things don't get done. And that's okay, because really what we're trying to do is create relationships that are long lasting, and that over time, hopefully some of those routine medical things can get done, but really we're trying to focus on the most important aspects, and then also focus on reducing HIV risk. And then for the She and Aurora clinic specifically, because we're located within Aurora Commons, we similarly exist in what I'd like to call a trauma-informed environment. So many of the pictures that I've shown, including this one, you can see that this is our clinic space, but it doesn't really look like a traditional medical clinic. So the physical environment here has been intentionally built out to not look medicalized and to look more like a living room, to look welcoming and warm. And that's the same with the Aurora Commons space itself. It's sort of built out to look like a cafe, and it's meant to be a place where people feel comfortable coming into and feel like they belong. And Aurora Commons really emphasizes and focuses on that sense of belonging, and that's something that really carries over into the clinic space as well. Next slide, please. And then, as Jimmy mentioned earlier in this talk, I think the third key element for both She and Aurora and Engage Health is this low barrier care model. And what we mean by that is really outlined here in this table. And this is adapted, thank you, from Julie, who I believe is on this call. And you can see that we define kind of the structural elements here, this walk-in access to care that is critical. Most of our folks really struggle to make any type of appointments. There's high intensity case management. And then the incentives are actually quite important to us, being able to incentivize returning for results, being able to incentivize certain types of testing, and being able to incentivize HIV care specifically to promote engagement. And I think it's also a very valuable thing for our patients, many of whom have a lot of food insecurities and don't have the means to access food or groceries or things like that otherwise. And then there's, of course, the process elements of low barrier care, which we've talked about throughout this presentation, this low barrier care philosophy that's really critical to our implementation of these clinics, cross-agency collaboration. I'll talk about that a little bit more in the next slide. And then this commitment to rapid modification. I think we're always trying to refine what we're doing to make it work for our patients better. And so we've had many meetings over the courses of several years talking about, hey, is this working? Can we do this differently? The pharmacy aspect is one key component to highlight there, where initially patients were going out to pick up their medications and it just wasn't working. And so we tried to figure out a way to meet them where they're at and get medications delivered. And there's, of course, still issues with that, right? Because people have to come back the next day and pick it up, but at least we're making steps towards achieving a better outcome. Next slide, please. Thanks. And then the last key kind of implementing characteristic that we wanted to highlight here was building and leveraging community relationships. So specifically highlighting cross-agency collaborations and even intra-agency collaborations. Because the needs of our patients are so complex, they're so varied, it's really impossible for us to provide everything that they need. And the establishment of impactful partnerships with other clinics or other organizations has really allowed us to extend the number of services our patients can access in a low barrier fashion. So a couple of examples of this, Dr. Maggie Green, who works up here at the She and Aurora Clinic, was really instrumental in forging a partnership with the UW Northgate Neighborhood Clinic, and specifically their family medicine program. And this clinic now reserves a select number of clinic appointment slots for She and Aurora patients who need low barrier OB and GYN services. And so we know that every Thursday afternoon, we have spots reserved for our patients and we can slot them in there. And specifically for our pregnant patients, this has been a tremendous way to get them into OB care, or for folks who want to prevent pregnancy has been a great way to offer long-acting reversible contraception. And then at the Engage clinics, they've established a great relationship with the Center for Multicultural Health in Spokane and have referred many patients of color to those individuals. So many Black individuals with HIV have gone to Spokane to receive additional services. And they've also been able to work closely with South King County REACH programs. Next slide.
So I'll talk
Jimmy,
a
I
little
think
bit.
it's back to you. Yeah.
Yeah. Sorry, I think there's a slight delay here. I'll talk a little bit more about some of the limitations and challenges. First off, because of just the footprint and the nature of the care, doing primary care, as we've kind of mentioned, like full-on primary care can be a challenge. Patients often come to the clinic with a specific urgent need, and meeting them where they are, oftentimes that trumps kind of the guideline-driven, we'll check you for diabetes, that could be potentially pushed for a later visit. And then that can be sometimes challenging to prioritize depending on, what their other needs are. And that also kind of translates over to what services we can offer within our small footprint and our small but mighty team. We might have to refer them to a different healthcare facility, or for us right now, for example, down south, we've had shrinking staffing right now, and depending on priorities and our capacity, we've had to refer folks to other to other places for more primary care or other things while we focus on kind of our core focus needs here. That can also be for mental health, OB, other specialty care. And then coordinating care and medications remains challenging, especially if patients don't have phones, or they're often stolen, or we aren't able to necessarily reach them. We can get them that podiatry visit, we can get them that surgery visit, but actually getting them there outside of just scheduling can be a little bit hard. And then, just like Maria said, sometimes actually getting them the medications, if it's delivered the next day, or they still need to make that trip from the clinic over to the pharmacy, that's hard, and they often have either transportation challenges or other competing priorities during that day, or if they don't have an ID. It's amazing what you need an address for. A lot of these things are difficult, and we have ways to try and do that, whether it's through ride shares or putting them in a cab, or helping them out with Hope. But it's still a challenge getting them ultimately sometimes our clients to where they need to be. And then building on either some things for Engage, or potentially even when Aurora and She were building up, staffing and turnover has been a difficult thing. And this is both for our partner organizations and also our own clinic itself. Once someone has gained a lot of knowledge and working relationships with either our partners or with our various clients, if they move on to a different position, oftentimes that's great for them, but it also building back up again. And so that has been challenging as we've grown out these clinics or building out the clinics. And that has impacts both on team and also partnerships and our clients. The intensity of the environment can sometimes be part of that reason, and so it's important that as a team, we work together along with our partners to work towards making sure that folks aren't burnt out, and we're resilient, and also understanding where boundaries are. And then oftentimes, as we're growing the programs, the different cultures at each of the organizations, it sometimes takes a little bit more time for the two organizations to jive. There's different structures, different priorities, learning the lingo of each organization, what's possible. That's been a great kind of learning experience, either with our partners. I can speak to at Engage, working with CCS. It's been a great learning experience. We've really grown with our own with CCS's staff here. And at Engage, Kent didn't open for almost 9 months after our first clinic opened up, and that build out time and space, there was a lot of learning how long IT took to actually get going. So, and finally, in relation to kind of the limited aspects of we're a small footprint, we always want to be nimble and be able to rapidly change to the needs of our clients and our also funding and all that. And so sometimes adding more services or refocusing services can be something that we need to revisit. For example, there's a lot of new interventions out there from long-acting injectables. It'd be great if we could get them from both HIV and substance use treatment at the low barrier clinics, but we're trying to figure these things out. And how does that fit within our own partner organizations' footprint? These are things that we are still talking about and thinking about. And then finally, funding, that's always a challenge sometimes in this space, in this work, with some of the changes in EHE, HRSA, DOH, and SAMHSA. We have to be creative in terms of how to where we get our funding and how and what services we offer. One of the takeaways from a lot of the other status neutral clinics in Chicago, New York, Dallas, San Francisco, they all talk about having a diverse portfolio of grants and other sources to be able to fund the work, and that includes the CBOs that we work with. So a lot of different things to think about as we kind of build out these clinics. I'll turn it over to Maria for the last portion here.
Great. And our last slide here, I just wanted to highlight some local next steps in scale up. Dr. Dombrowski has an R01 focusing on impact of viral focusing on the low barrier care clinics, impact on viral suppression for HIV, as well as evaluation of the implementation and costing. And then I have a R34 from NIDA that is, along with Dr. Janelle Stewart, who's MPI on that, looking at the impact of an evening pop-up extension of SHE Clinic on uptake and sustained use of PrEP and buprenorphine. And then with a CFAR supplement headed by Dr. Lydia Chwastiak from psychiatry, we are embedding brief narrative therapy into the SHE and Aurora clinics. And with that, we'd just like to highlight our acknowledgements and thank all of these people listed here on the screen. I apologize for taking the whole time, but we'd be happy to answer any questions, or feel free to send us questions via email as well.